Thanks, Andrew, and thanks everyone for joining us here today. So my name is Jeremy Tanner. I'm a behavioral neurology fellow at UCSF in San Francisco, and we're very excited to have Dr. Melody Asukile join us today to talk about teleneurology for epilepsy care and education in Sub-Saharan Africa. So Dr. Asukile is an attending neurologist at the University Teaching Hospital in Lusaka, Zambia, and currently oversees the EEG lab and co-manages the EMG lab there. She has a special interest in the use of telemedicine for both patient care and medical education. She previously completed her neurology residency at the University of Cape Town in South Africa, and will soon be beginning an epilepsy fellowship at the University of Cape Town as well, with funding from the International Federation of Clinical Neuropsychology. We're very thankful she's willing to join us here today to talk with us. So without further ado, I'll hand it over to her.
Hello, thank you so much. It's such an honor to be invited to give this talk, and I'm really excited to just share some of my thoughts on epilepsy and education. So as Jeremy said, I'm going to talk about virtual platforms for epilepsy care and training in Sub-Saharan Africa. So I have no relevant disclosures for this talk, and this is just an outline of some of the things that we're going to discuss today. So I think for a start is to talk about epilepsy in Sub-Saharan Africa. So epilepsy, as we know, is one of the leading causes of neurological disease and disability, not only globally, but specifically in Sub-Saharan Africa, where the highest number of patients with epilepsy lie, and the highest treatment gap also lies in Sub-Saharan Africa. The biggest challenges that we face with managing epilepsy in our region is the lack of neurologists, the lack of access to anti-seizure medications, and poor knowledge about the condition, which is shrouded in so many myths and so much stigma for our patients. Low and middle income countries have the fewest neurologists per population. So in high income countries, this could average about 4.7, 4.8 per 100,000. But in our region, we're talking about 0.3 per 100,000, so less than 0.5% per 100,000. And yet we have the largest neurological disease burden. The majority of our patients with epilepsy are therefore managed not by specialists, not by neurologists, but by general family doctors. And in many cases, especially in rural areas, by nurses or medical practitioner assistants, who in our country are called clinical officers. So what about telemedicine in our region? So telemedicine is the use of telecommunications or virtual platforms to provide healthcare remotely. And we are beginning to think that it might be a way to improve access to the limited specialist care that we have in our region. So over the years, telemedicine in Africa has mostly relied on international experts abroad. So these are colleagues in Europe, in the UK, in the United States of America, to provide guidance remotely. And the use of telemedicine in Africa has really been limited by the lack of infrastructure and the lack of access to reliable internet services. However, in the recent past, we've seen a boom and a growth in mobile phone networks and in access to internet services. And so this is actually a breakthrough with regards to trying to improve telemedicine in our region. Another issue has been the COVID-19 pandemic that we've faced in the last 3 years or so. And this actually led to a global increase in the use of telemedicine, including in low middle income countries. And so the question is, can we leverage local expertise to use telemedicine in our region rather than relying on experts from abroad? So more recently, we've had local experts that are employing telemedicine to provide services to other regions within the same country. However, little is known about neurology or epilepsy. So some examples I can cite in Mali, where local radiologists will report x-rays and imaging remotely. Again, is a teleophthalmology project in Zimbabwe, where remote retinal images would be taken in a rural area and an ophthalmologist in the capital would report them. Similarly, GPs or general practitioners in Cameroon would be linked to experts who would give both live and asynchronous advice to doctors in areas where there are no specialists. And when we come to thinking about teleneurology during the COVID-19 pandemic, as I said, we've seen an expansion because teleneurology was a way that you could see your patient without actually being in the same room with them, which was the hallmark of COVID-19 with physical distancing. And so low and middle income countries started reporting the use of teleneurology as well. And so one example is in Mexico, where they developed a teleneurology program during the COVID-19 pandemic. For their program, they used mostly WhatsApp video calls. And since we're speaking specifically about epilepsy, they saw about 11% of their consultations were epilepsy, though majority were neuromuscular conditions and headaches. 96% of their patients were satisfied with the service, and 86% actually preferred them to an in-person visit. Again, a bit closer to home, I'd like to highlight a program that was conducted in Kenya. This was a small pilot program by Professor Soki at Aga Khan University Hospital in Kenya. And he came up as well with a way to see his patients during the COVID pandemic. He contacted 58, 31 of whom agreed to audio teleconsult. So this did not involve any video. 12 decided to wait. And he had 26 who completed post-visit satisfaction surveys. So from his survey, he found that all the patients were actually satisfied with the televisit. They felt their health issue was addressed. They were happy to have a teleconsult in future and would actually recommend the teleconsult. And one important finding was as well that they saved more than 10 kilometers of travel. So a lot of times, even in our country, because your specialists are in limited areas in the big cities, patients sometimes have to travel hundreds of kilometers to see a specialist. And so in the case where they managed to have a teleconsult, they saved on some of this traveling distance. And so what about teleneurology for epilepsy management? So we spoke generally about epilepsy, about neurology, but then when we think about epilepsy, we actually don't have much data about teleneurology for epilepsy. There is a project, one of the countries that it runs is in Malawi, called the DREAM project. So the DREAM project is a multinational project that's actually HIV focused, but within that, they've got sub diseases that they would address. And so there's some reports that they gave on management of stroke and epilepsy. And through this DREAM project, they also provided a video EEG service with remote reporting. So an EEG would be acquired in Malawi, for example, and then it would be sent to a neurologist abroad who would report it. And similarly, consultations would be made with neurologists who are abroad. Another application that's been developed in Nepal is an epilepsy diagnosis aid application, which is a smartphone application that helps non-specialist health workers on making a diagnosis of seizures. And then once this diagnosis is made, it's followed up with a televisit with a specialist. So I want to just come back closer to home now and talk about our experience in Zambia with the use of teleneurology. So we too, like the rest of the world, were compelled during COVID to find ways in which we could actually improve our service to patients. There are two services that we've employed and that I'll share with you. One is a public-private partnership that we actually started even before the COVID-19 pandemic. And the second one is a clinic that we instituted during the COVID-19 pandemic. And so with this public-private partnership, there is a clinic that is in a remote area, but it's a private clinic, which is called Maryburg Health Services. It's about 600 kilometers away from Lusaka, or 360 miles. And these, they do not have specialists there. So they run quite a well-equipped clinic, but they wanted neurologists or specialist input. And so we came into a partnership with the University Teaching Hospital, which is a public institution. And so we made a program in which we had bi-monthly clinics. And so this would be a Zoom clinic or a Zoom visit in which the doctor, a primary care physician, and the patient would be in a consulting room at the clinic in Solwezi. And then you would have the doctor, the neurologist in Lusaka, and we have a consultation that way. At the time I was doing this report, we've had about 45 visits. And from these visits, we did satisfaction surveys. Of note, about 40% of the patients we see are actually patients presenting with epilepsy or seizures. and a similar number presenting with headaches. So satisfaction surveys are collected from both patients and physicians. And we find that overall, both patients and physicians are satisfied with the service. And they do feel that a televisit does provide adequate understanding of the condition, both for the patient and also for the primary care physician who's taking care of the patient. Secondly is the teleneurology clinic that I would like to share during the peak of the COVID-19 pandemic. So at the peak of the pandemic, like in many places, our outpatient clinics were suspended. And so we realized there was going to be a gap in care for our patients, and we needed a way in which we could continue care, at least to some degree, so that our patients didn't lose out on the treatment that they needed. So we implemented a teleneurology clinic, and for all those patients who had appointments between June and July of 2020, and those who had missed appointments between March and May of 2020, we called to ask if they were agreeable to a televisit. We conducted televisits over the phone through WhatsApp video or Zoom calls based on what the patient had accessible to them. 80% of our visits were actually by telephone call alone. So this is just a flow of the way we saw our patients. And so we contacted about 300 patients, 190 were reachable. And of those, about 133 agreed to the televisit, and we performed the visit. About 3 to 4 months later, one of the nurses who wasn't part of these visits would call the patients to gauge their satisfaction. And similarly, we asked the neurologists who participated to fill out self-administered online surveys about their satisfaction. Speaking specifically to epilepsy, about 20% of the patients we saw presented with epilepsy or seizures, and stroke, I think like in many general neurology clinics, was the highest number at 30%. So some of the quotes when we asked the patients how they felt about the televisits, I think some of the reasons they gave for preferring televisits is that they thought it was less expensive. And putting this into context, as I said, the only neurologists in Zambia are at the University Teaching Hospital. And so patients will travel from all over the country, sometimes even up to 600, 700, 800 kilometers to get the clinic. They'll have to have accommodation to get the clinic. They need transport. And so if you think about it, a televisit for them is then more cost effective or less expensive because they cut out on some of those costs. In a similar way, some thought that there was less time involved. Many of our patients, when they come to the clinic, each clinic is usually manned by about 4 neurologists at a time, but we'll see about 50 to 60 patients. And so each patient is probably waiting anywhere from 2 to 4 hours before they are seen. And so them saying it was less time involved can also be understood in that context. Other reasons, patients felt there was more privacy and it was less an inconvenience when it came to mobility. I think the one reason that patients stated for not preferring a televisit is the lack of the physical examination. So for those who had video, we would do a video modified examination. But as you can imagine, on a telephone call, you couldn't do an examination. And some patients felt that that was an important aspect that they were missing out from the televisit. And so overall, in terms of satisfaction, the table on the left shows the level of satisfaction. In this scale, 1 means very satisfied and 5 not satisfied. And so you can see that for many of these aspects, in terms of the quality of the visit, the overall satisfaction of the visit was high. It was interesting to note that patients were more satisfied about their own comfort and privacy as opposed to physicians. So physicians perceived that the patient wasn't comfortable in that situation, but the patients themselves actually reported being comfortable. So that was an interesting finding. What was also really interesting for us was the outcomes of the televisits. So of these 133 patients, 30% were actually deemed stable and discharged from the neurology clinic. So these were patients, when you speak to them, you find that it's someone who's maybe had a stroke many years ago, they are stable, their risk factors are under control, and they actually do not need further follow-up in a specialist clinic, but can be followed up by their general practitioner. Another 30% were a group of patients who, though they did need ongoing specialist care, they were stable and their medications were keeping them under control. And so these were patients who we could actually book for a clinic later. We would write out a prescription and they could come and collect it from the clinic at a time convenient to them, which would be at a time as well when the clinic would not be crowded. And so this was an interesting finding for us, that a good number of our patients could actually be managed remotely in this way. 19% of our patients, though, did need an in-person visit arranged. And these were usually new patients we had never seen before, or patients who had developed new symptoms or needed a more complicated adjustment to their medication. So in conclusion, we found that teleneurology visits were an acceptable means of service provision for adults attending the UTH Neurology Clinic during the COVID-19 pandemic. We think they're a promising supplement to in-person visits in resource-limited settings, even when video call support is absent. We recommend considering continuation of teleneurology visits for selected patients. And I think we did notice that it was much easier if it was a follow-up patient, so someone you had seen before and you were now following up and they were stable. And also for certain conditions, for example, like headache, those could be conditions that could be discussed over the phone, and we could continue these services even beyond the COVID-19 pandemic. There are some limitations and some challenges that we need to consider, particularly with regards to reimbursement. So this was a non-funded study, but going forward, there's the issue of data, there's the issue of devices, but we felt that if you look at the overall big picture, it's actually more beneficial than not. Okay, so the next aspect I think I want to look at, so we've talked about epilepsy care and providing care through teleneurology and telemedicine. I think something that's very closely linked to this is education. So not only neurology education, but in this specific talk, I want to talk about epilepsy and EEG training. So as I've said and spoken to, I think over and over again, is we've got very few neurologists in Sub-Saharan Africa. And so neurology teaching is compromised. And this also now goes to EEG or electroencephalography training, because not only do we have few neurologists, but then we have even fewer epileptologists. So with this background, the University of Cape Town, or UCT, in conjunction with the World Federation of Neurology, WFN, developed a comprehensive 6-month web-based EEG course called EEGONLINE. So over the last 4 years, it has seen over 800 registered learners. Currently, with this year, we've got, I think, about 250, and with 90% coming from Sub-Saharan Africa. And thus, we are building the capacity for EEG in Sub-Saharan Africa. The course is ideal, I think, because it uses regional experts to provide up-to-date, but also regionally relevant content. So this is a map that just shows the extent or the regions where our participants come from. So as you can see, we've got learners who are registering from all over the world. The stars are not representative of the numbers. So Africa, though having 1 star in each country, has a lot of people per country. So majority of our participants or learners are coming from Africa, but we've got people registering really from all over the world, which is also really encouraging. And so I just wanted to share some of the features that the EEGONLINE program has. So we call it a multimodality teaching platform because we use different teaching methods or teaching modalities to stress the point or to teach on certain topics. So one of the ways is we have illustrative text. So each module has text with images. I'm talking about a certain EEG topic. And then we've got audio and video lectures. So these lectures are recorded by the tutors of the course. So they are pre-recorded videos and pre-recorded audio lectures. Then we've got a section called Interactive EEG Epoch Activities. So again, these focus on a certain topic. For example, this one is on focal epilepsy from discharges and slowing. And it's interactive in that as you read the text, as you hover over some of the colored words, they'll highlight certain areas of interest on the EEG snapshot or epoch. And in that case, in that way, you interact with the EEG epoch. Another really popular aspect of the course is these intra-module or end of module quizzes. So the program has 8 initial modules, and after each module, which lasts about 2 to 4 weeks, there's a 30-question multiple choice quiz of all the different EEGs that were discussed during that module. You can take the quiz as many times as you can, and when you're done, it gives you feedback with answers and explanations. And many of our learners really enjoy that. There's also discussion fora where the tutors will post different EEG problems, and the learners on the course can discuss among themselves. And at the end of the week, the tutor will give the answers to those problems. So with assessment on the EEG online course, assessment is done through the quizzes that the participants or the learners do. And we also look at their course activity through the times they're logging on, the learning material they're accessing. And then finally, at the end of the course, after the end of the 6 months, there are 3 final examinations, multiple choice examination questions. And when you pass with a pass mark of 65% or more, then you qualify to have a certificate from the course. So during my neurology residency, I was doing a Master of Medicine thesis. And so my thesis was evaluating the efficacy of this EEG learning program. And the question was, is an online tool for EEG teaching effective? So this was a prospective cohort study, which was conducted to evaluate the efficacy of this program in improving EEG analysis skills. We enrolled 128 learners, and these comprised neurologists, neurology residents, and neurology clinical technologists. And 91 of those who were enrolled completed the study. The study comprised 2 components, or 3 in a sense. So the first one was pre and post-course multiple choice question tests, which assessed the knowledge acquisition. And then we had pre and post-course surveys, which assessed satisfaction and confidence in EEG analysis, subjective confidence. And then finally, we also looked at the use of course materials, and then we correlated that to performance. So this is a study flow of how our program worked. The recruitment was in 2 cohorts. So we recruited participants from 2017 and 2018, and both of these groups underwent a pre-course test and survey. Then they had 6 months of teaching, which is the 9 modules of the EEG online course. And then there was a post-course test at the end to assess the acquisition of knowledge. Our participants were mostly neurologists, either qualified or trainees, so about equal numbers of neurologists, residents, and neurologists. Then we had a couple of technologists as well. As I mentioned from the course over the years, majority of our participants are from Sub-Saharan Africa, though in this particular study, we had a few from North Africa, Europe, and North America. And so this is really the major findings of our study. And the 2 things were that there was significant improvement in subjective confidence, particularly for neurologists and neurology residents, from before the program to after the program. So we asked them about their confidence in different aspects of EEG analysis and their overall confidence, and this significantly improved at the end of the course. The second thing we looked at is overall knowledge. And again, we found that the average test scores significantly improved from before the course and after. And this was most significant again for the neurologists and the neurology residents. I think one thing that we found quite important was that we noticed that the improvement in the knowledge acquisition was largest for normal features and for artifacts, which we thought was quite useful because learners were now able to identify what's normal and not call normal features abnormal. This is quite a busy table, but it's really just a breakdown of some of the features that we were looking at in terms of overall improvement. And one thing we noted, as I said, normal EEG variants in particular showed big improvements. And so it was very reassuring for us that participants or learners could now identify, for example, normal variants like Wickett waves and V waves. They could identify that those were normal and not abnormal. And also there was increased confidence in identifying abnormal non-epileptiform waveforms. So one of the pitfalls of EEG reading is when you call something that is normal abnormal. And I think it was reassuring for us to know that our learners were improving in these particular aspects. Another really busy slide, but which this one really is looking at the use of the course. And so we divided it into those who use the course a lot versus those who didn't use it so much. What we did find though is that regardless of the amount of use of the course, there seemed to be an improvement overall. It was noted though that those who use the course more tended to do better than those who use it less, but we didn't actually find a significant difference between the two groups. One thing that we identified in the course is that participants particularly liked the illustrative text or the lecture notes, and also really enjoyed and used mostly the intramodule quizzes. So when we asked the learners how they felt about the course, I think all our participants were satisfied with the course. They felt that it improved their EEG analysis skills. They felt it improved their ability to analyze EEGs independently. About 70% felt it made a difference in the way they manage their patients. And almost all the participants felt that it was a useful learning tool and would recommend similar tools for other neurology teaching. So from this study, we demonstrated that a multimodal online EEG teaching tool was effective in improving EEG analysis and interpretation skills. We think it's a useful supplement for EEG teaching. It is not easy to replace in-person teaching, but it can definitely supplement, especially in areas where you've got very few epileptologists or none at all. It can be a useful supplement in resource-limited settings. And given the optimistic findings of this study, we would encourage the development and evaluation of further online neurology teaching tools. So moving on, I would like to talk about, again, back in our country, virtual neurology lectures in Zambia. And so as a background to this, in 2018, Zambia developed its first ever neurology training program under the leadership of Professor Diana Saylor from Johns Hopkins, and so far has graduated 7 neurologists. So when the program just started, because Zambia had no Zambian neurologists, and we relied on visiting neurologists, expert neurologists, a lot of whom do a lot of research work. And so when the program started, it relied on a lot of visiting neurologists who would come for short periods of time and provide that additional training to the local residents. However, the COVID-19 pandemic hit, and just like with our clinics, we had to come up with a way of continuing teaching for our neurology residents. So since then, most of our lectures, our case conferences, our journal club are provided in a hybrid fashion. So we resorted to doing a lot of things by Zoom, but then we would still have in-person sessions where possible. So this method of having these lectures via Zoom has really opened up our service to residents from all over the country and the region, e.g. Ghana, Kenya, Tanzania, and Nigeria. So it has also allowed us to get talks from specialists from all over the world. And we have held online courses through this online program, such as the neurocritical care course, and we did a survey on this, and our participants found it quite satisfactory. Specifically for epilepsy teaching, our residents also receive weekly EEG teaching from epilepsy specialists at Johns Hopkins. And so they are now getting this regular teaching through a remote service. Another way we are hoping to contribute to the body of education in Sub-Saharan Africa is that we are recording our lectures on an online medical education service called VUMEDI, and this is accessible and free to all who register for the service. So coming close to the conclusion, I think I want to talk about some of the future directions of using telemedicine for epilepsy care and for education. So one of the ways is remote EEG reporting using applications like TeamViewer, for example, or asynchronous reporting where you can download the EEGs. So at present, EEGs are remoted remotely from our hospital by myself and other colleagues. So a lot of times our machine during the day is being used. We only have the one machine. So that machine is being used for recording. And so later on when the clinic is closed, then myself and my colleagues would then report the EEGs remotely. And we hope that we can expand this service even to other regions in the country. So we've got different centers across the country which actually have EEG machines, but they don't have a neurologist there. And so what we're hoping to do is to train some technologists who can be able to acquire good quality EEGs, and then a neurologist anywhere in Zambia or even abroad would be able to offer reports. Another thing with regards to education is we would like to build on the online EEG teaching platform to include more advanced courses. So the EEG online course I talked about, this is more of an introduction to EEG. So it teaches you the basics of EEG. It teaches you how to basically apply EEG, but we hope then that we can generate more advanced courses for those who want to learn a bit more about EEG. And similarly, as I talked about, to explore the potential of other neurology teaching courses. And this could include introductory courses, for example, in electromyography and nerve conduction studies. Additionally, with regards to the teleneurology clinics, our pilot clinic showed that there's potential and it could be potentially beneficial. Our clinic with the doctors at the private clinic that I talked about showed that over time, they've actually improved their neurology knowledge. So as we see patients more with the primary care doctor there, we come to realize that they've actually been learning neurology. And by the time sometimes we see the patient, they're already managing the patients appropriately. And so we thought that we could use a similar method by setting up teleneurology clinics at some of our government hospitals who have general medicine residents. And in this way, we can have virtual clinics with the doctor and patient at a regional site and the neurologist in Lusaka. And this will serve as a platform not only for specialist neurology patient care, but also neurology training for the doctor who will be on the other side. And lastly, as I talked about, we are every week recording our neurology lectures, and we hope that we can provide additional neurology learning for our region. So in conclusion, epilepsy burden is highest in Sub-Saharan Africa. And yet we have the fewest neurologists and we have the least access to adequate care and treatment. The COVID-19 pandemic has further limited access to healthcare for all patients, including those with epilepsy. We think virtual platforms may be an option for expanding access to neurology specialist care and training in low and middle income countries, especially now that we've got these widespread mobile phone networks which provide internet even in remote areas. And I think from the experience that we've seen both from ourselves and from our colleagues in Mexico is that you do not necessarily need video capable devices for selected patients. And so this should not be a hindrance to teleneurology use. I just want to end by recognizing my very wonderful neurology team in Zambia. So we've got Prof. Diana Saylor, Dr. Zimba, Dr. Chomba, Chimba, Mata, Kawatu Nkole, and all the big team. The team keeps growing. And also to acknowledge the EEG online team. So these are the main tutors There are some who are not in the photo, but there is Dr. Lee Pan on the left, Dr. Tucker, myself, Professor Eastman, and our honorary member, who's a cardiologist, Dr. Charles Villian. Thank you very much.
Thank you so much, Dr. Asukile, I think I can speak for everyone in saying for your extensive efforts on a clinical research and educational basis and taking advantage and helping to characterize this new telemedicine opportunity that's been fostered through the COVID pandemic and can hopefully help to overcome many barriers in terms of access to care and education and transportation as well. And for letting us know about all of these tools that are available for learning neurology.